Hello, everyone. We're going to continue with our concept of immunity and talk about organ transplantation. So, we're really going to focus on what this is like for a person who has had an organ transplant. So, focus on all things immunity, rejection, medications, and things that they have to take care and think about. Be sure you have your outlines with you so you can take some notes on these. I've made those outlines in bulleted list, but you really need to take notes as you need them for yourself to understand the process. So let's just do a little bit of overview. I did snag the picture from your textbook that shows about which organs and tissues. Tissues include things like cornea, bone marrow, skin, heart valves, bone, connective tissues, and then certainly organs: heart, lungs, liver, pancreas, kidneys. I think probably the most common organ that's transplanted is kidney. It can be a single organ or it can be a combo like a heart and lung together. It's whatever that patient needs. So the organ transplant is done for end-stage organ failure, so end-stage liver failure, end-stage respiratory failure, end-stage renal failure. And this can be emergent because the patient is so critically ill that they are not going to live without an organ, or it could be elective. And when I think elective, I think mainly of our kidney patients in end-stage renal disease, kidney disease, and who choose to be on the transplant list because they are very tired of having dialysis, hemodialysis 3 days a week, or doing peritoneal dialysis. So they are opting to go with a transplant so that they can stop dialysis and have a better life. So what happens with patients? They are screened and placed on a national wait list. Now, the way organs are picked, they are matched with donors by blood type, medical urgency, time on. Some of it is time on the wait list, geographic locations. You're not on the list. You don't go to the top of the list because you have more money. You don't go. The list isn't done by ethnicity, race, gender, any of those kinds of things. They're really going to match donors and recipients that are close by because some organs do not survive long. Long means hours after they are taken out of a donor, and they must be transplanted quickly. So all of that is done by the organ procurement team that works with the donor and the recipient. There is a organ procurement team, transplant team coordinator who certainly will work with the recipient, getting them on the list, what to expect while they're on the list, what to expect when they get that phone call at 2 o'clock in the morning that says, hey, there's a kidney ready. You need to be in your car in the next 15 minutes and get to the transplant facility because the day is here. Donors can be living or deceased. Living donors can be relatives. They can be complete strangers. Deceased donors are those patients who typically have had some kind of traumatic event that have been declared brain dead and have made their wishes known to their families that they want to be an organ donor. Certainly you can do that by your driver's license. Clearly on your driver's license it states whether you wanted to be an organ donor, because at the time that you're brain dead, we can't ask you. So if you feel very strongly one way or the other, whether you want to absolutely do it or absolutely never do it, you need to let your family know. And there is also what's called donation after cardiac death, and this is just FYI for you. These are patients who have irreversible neurological problems, who will not be awake, will not be able to take care of themselves, may or may not be able to come off a ventilator. They're not brain dead, but they are not able to live without lots of support, and they have made it known to their family that they do not want to live like that. So we can do donation after cardiac death. Okay, so let's talk about transplant rejections. This occurs when the recipient's body has an immune reaction to the transplanted organ or tissue because it sees it as foreign. Even though we're doing all this cross-matching with blood type and all of those sorts of things, the body knows that, hey, wait a minute, this is foreign. Antigens in the organ or tissue activates the recipient's T cells and stimulate this inflammatory process. So there are three types. We do have hyperacute, which occurs within 24 hours of transplant, acute, which is in the first 6 months, and then chronic, which is over months to years. So in the hyperacute, we have lots of destruction that's going on. The recipient has pre-existing antibodies against the transplanted tissue. The only treatment is to remove that transplanted organ or tissue. This is pretty rare because of all the testing that's done prior to transplantation, and we have improved immunosuppressant medications that we are going to give. So what we have to do in this post-transplant time is basic routine post-op care and infection prevention to certainly make sure that they don't get an infection. The acute is within that first 6 months, and this is usually reversible, and they will require additional immunosuppressive therapy. So everybody with an organ transplant or tissue transplant will go home taking multiple immunosuppressants. So that gives you a real idea of what we've got to teach our patient, the medications they're going to be on, side effects, and things like that. So what happens in this acute phase is we have a cell-mediated immune response by the recipient's lymphocytes, and that's been activated because of this donated tissue and organs. These are usually reversible, as I said. We add additional immunosuppressant therapy, and these patients will need a long-term immunosuppressant therapy, which certainly puts them at risk for infection. So our chronic is over months to years, and this is usually irreversible. It happens for unknown reasons related to episodes of acute rejection or stopping their immunosuppressant therapy. We actually saw that recently with a patient who had had an organ transplant for many years and maybe over a decade, who for whatever reason just stopped immunosuppressant therapy. We actually had them back in with end organ failure because of stopping the immunosuppressant therapy, which really did make me wonder what was going on in this patient's life, that they had done this for so many years and over the course of the last 2 years just decided to stop the therapy. And those are something we really need to talk to them about. Usually in this chronic thing, treatment is supportive. Prevention, early diagnosis, and treatment of rejection are essential so that we don't have long-term graft function issues. Okay, so let's talk, we'll get to pharmacology. I did include collaboration because there's not really a lot, there's not a specific section in your textbook about organ transplant. It's kind of scattered all over, so I've kind of curated everything to you in a big list. We're going to have our healthcare providers and certainly our specialists. Whatever organs failure is failing, we'll have that specialist. We'll have the transplant team. We'll have the transplant coordinator, and that coordinator is helping the recipient. There's also a coordinator for the donor that takes over care. So once a patient's been declared brain dead, this happens in the ICUs, the transplant coordinator will come and really guide what we're doing for that patient, because we are working hard to keep that organ alive and well perfused, or multiple organs if we're doing multiple organs. We'll need respiratory therapy, pharmacy, social worker, case managers, spiritual care. And when we think of organ transplant, we need to think of donor and recipients. Certainly, we're focusing more on the recipients, but if we do need to think about the aspect of a donor who has been declared brain dead and the grieving process for that family. This is very difficult. There are families who will just absolutely refuse to donate organs. Um, they just can't do that. All patients, the standard here with our facilities is the organ procurement team, Life Gift is the company that we use, must be contacted for all deaths. If we do have someone that we think might be an organ donor because of massive trauma, they are called in early so that they can come and look at those charts and kind of start thinking about, is this going to work? And they are the ones who talk to these families, because these families have lots and lots of questions and things like that. Diagnostic imaging. Diagnostic tests, really we're looking at lab tests specific to those organs. So if it's liver, we're looking at our LFT, liver function test, cardiac, respiratory, renal functions, imaging specific to that. Okay, so let's talk about this immunosuppressive therapy. It's got to be taken for life. They do have significant side effects. There is risk for toxicity, and that risk is continued for the rest of their life. And most of these immunosuppressants do increase the risk for developing things like cancers. Doses may be decreased over time. Initially, they will be on triple therapy for your CNIs, your corticosteroids, and your monoclonal antibodies. Anybody on immunosuppressive therapy has increased risk for infection, so we absolutely have to do our part to decrease that infection and put them on contact precautions, neutropenic precautions, and teach them what that looks like. So I've chosen 4 headings of medication. So the first is CNI, so cyclosporins, and I'm going to try really hard not to butcher these names. Tacrolimus, those are the most common ones that we see. They can be nephrotoxic, hepatic toxic, they can have tremors, seizures, hypertension, leukopenia. Certainly corticosteroids and prednisones you know very well, and the things that can happen with that. They can have ulcers, hypertension, osteoporosis, sodium and water retention, bruising, delayed wound healing, increased blood pressure. So these patients are going to have to monitor their blood pressures every day. They're going to have to monitor their blood glucose. They're going to come in very frequently for medical care once they've had a transplant and spent that time in the hospital. When they leave the hospital, they actually stay close to that medical facility. So if you're in Amarillo or some small community outside Amarillo, you're in the Dallas area or the Houston area or the Austin area or the Denver area or wherever transplant that you went to, and you will have to stay there for at least a month, if not 6 weeks, because you will be going in and having testing and seeing healthcare providers up to about 4 times a week. Our cytotoxins, our anti-proliferation medications, monophenolate is also called Cellcept, so that may be a trade name that you're used to hearing. They will suppress bone marrow, so you'll have neutropenia, anemia, thrombocytopenia. Anemia and thrombocytopenia we've already talked about in this class, nausea, vomiting, diarrhea. Then our monoclonal antibodies, fever, headache, muscle pain, GI issues. So all of these medications, they're going to be on triple medications, so they can take upwards of about 40 medications a day. They do have some similar side effects and certainly this immunosuppression. So that should lead you to thinking about what's going to be important for you to teach. Okay, so let's talk about our nursing care, nursing interventions. So assessment and post-op care. So if you have these post-op period. It's routine post-op care that we always do, and then certainly looking at functions of that organ. So if it's kidneys, am I getting urine output? Do I have a base level of urine output? For this patient, it could be 30 mils per hour. They may also be using the zero point 0.5 mils per kilo, 0.5 to 1 mils per kilo per hour urine output. If it's renal, we've got to monitor that urine for what does it look like. Does it have blood clots? If it does, we may have to flush because we need it to come out and not get occluded. If it's heart and lungs, what is their cardiac output? Are they able to breathe on their own? What do their lung functions look? We absolutely have to prevent healthcare acquired infections, healthcare associated infections, so your HCAIs. So we need to do neutropenic precautions, wear our gowns, our gloves, our face masks, and not give these patients any kind of infections, and our visitors will have to do that as well. So education, medication and administration, they have to take these medications on time, correctly, and consistently, which means they've got to have a planner, they've got to have pill boxes, they've got to, keep their table, set alarms on their phone or whatever, and do these. Of note for medications, especially if we're talking about children, because people of all ages, infants, children, adolescents, adults, older adults can qualify and get organs. Some of these medications can cause things like birth defects. So if you have a mom giving these medications to their child who's had an organ transplant, they will need to wear gloves so that they don't get any harmful effects from these. Absolutely no over-the-counter medications or herbs without talking to their healthcare providers to find out if those are okay. We need to teach them signs of rejection, so not feeling well, flu-like symptoms, pain, swelling at the transplant site, organ function decline and related symptoms, and that should be really easy. It's those signs and symptoms that they had before. What is long-term care going to look like for them? They've got lots of routine follow up with their healthcare provider and for labs, preventing infections. So I gave you a bulleted list of the things we have to do. We need good hygiene. They need to wash their hands frequently, shower and bathe frequently, maintain good oral health, use a soft toothbrush, environment, avoid crowds and limit contact with people who are sick. When you go out, they're going to need to wear a mask. Don't share food, drinks, straws, cups. Clean your environment. Food safety. You need to thoroughly cook meat and eggs. And a thoroughly cooked egg is a thoroughly cooked white and egg yolk that is considered thoroughly cooked. If you like a runny egg yolk, that is not considered. That is a food safety. Could transmit disease. So, little FYI. Avoid raw foods. So, can't have things like sushi. Wash your fruits and vegetables. That's really important because foodborne illnesses are, for the most part, coming from fruits and vegetables. Safe food handling. Wear gloves if you're cutting raw meat. Use a separate cutting board for raw meat versus your vegetables and fruits. They need to protect their skin from direct contact with pet waste, that's urine and feces. Wear gloves if they're cleaning up after a pet, and then thoroughly wash their hands. Certainly if they can have a family member do that, that would work as well. You've got to use gloves with gardening because soil is a living thing with lots of organisms and, the good stuff that we need, and it's got fertilizer in it, and all of that is great to make your flowers pretty and your vegetable garden look great, but not good if you're immunosuppressed. These patients may need daily blood pressure monitoring and control, especially if they've had kidney transplant. They may need to monitor their blood glucose as well. Certainly no contact sports, routine post-op get up and walk, no driving for several weeks, those basic things. They are increased risk for cancer, so they do need some routine screenings for that, routine sun protection, and then psychosocial support for them and their family. Organ recipients know that they got, unless a family member gave them a kidney, that they are getting organs from somebody who is deceased, and somebody's family made a very difficult decision because their family member was brain dead. There are times that the recipient and the donor's family can get together. Usually there is some time between the donation before that starts, and that's really driven by the donor family. So lifespan considerations, all ages. We can have a newborn with congenital heart defects that needs a heart. And think about, all organs are hard to get, but we can't transplant adult organs into infants and children. We need an infant or a child organ for those people. Survival rates after transplant are improving over time due to advances in medical technologies and treatments, and individuals are living for decades with a transplanted organ, and that is not uncommon. Sometimes they may not have decades of an organ, even if they did everything correctly, which is why teaching them about rejection is so important. All right, so that wraps us up. Sorry, this is about 5 minutes longer than I intended. Certainly go through your nursing process questions, which are on the end of your outline, so that you can answer those and think about all aspects of your nursing care for these patients. Thank you.